First of all, thank you taking time for me.
Oh, you're welcome.
I,
Absolutely.
I waited so long time. I saw you in the Airway Collaborative together with Barry Raphael in this meeting, and then I wrote you, and somehow months later I got that information. How did it come?
Great. Yeah, no, it's great.
Yeah.
Yeah. So what struck you or what did you like that you saw from my presentation?
So I was impressed how you deal with the children.
Yeah.
That's the
Yeah.
question. The
Okay.
children. What are you doing, and so on. This was my main interest. Children.
Okay. Okay. No, that's great. And the main thing we want to do is get both jaws developed up and forward as much as we can.
Yeah. Children is always a little bit special. It's a big part, you know, it's the most important part, the 0 to 6, to make them grow forward. And that's what I saw in your presentations, and that's why I wrote you.
Okay, great. Yeah, no, that's great. So the main thing is, first I want to start with your background and what other courses you've done.
You know, I'm a course mentor, so I'm a general dentist. I'm doing everything. I'm an oral surgeon, but in Germany, the system is different. You know, we are mainly generals. We are not as specialized as you are specialized in pros, perio, and so on. So I have a wide field. You know John Coyce in Seattle?
Mm-hmm.
Yes, I did the whole program, and I'm a mentor there. And that's so I'm doing everything.
Well, let me go over some other options and treatments that are out there, and then we'll kind of follow the schedule that Ashley has, and we'll review as many cases as you want to look at. I'll look at them with you.
Yeah, great.
So, okay, I'm going to do a share screen here.
Okay, so we have a 7-year-old girl.
Mm-hmm.
This is a 7-year-old girl.
Okay.
So this is the position she's normally doing, forward head position. And then when I tell her, take the head a little bit down, so to see, you know, she's the lower jaw back, upper jaw a little bit back. This is her smile, and portrays from a lateral again, and the tongue. I'm checking tongue mobility, tongue tie, and so on. No problem. I was not able to see the pharynx, you know, because she is gagging.
Okay.
And this is the situation. Now, and in these cases, like her, I started with Myobrace, you know, and she likes the Myobrace. She has Myobrace in the mouth the whole night. That means she's nasal breathing, and that's a big thing, you know. So that's how I start and do the exercises with Myobrace, breathing and then swallowing and this on, and then we go on. But now she's 7 years old, and then I have a questionnaire, of course. Children airway questionnaire, like it's in German here. She has too many yeses in this questionnaire from the mother.
Mm-hmm. Mm-hmm.
What would you do with 7 years old?
I would use one of my airway appliances. So the Myobrace is a good tool. I was one of the first Myobrace certified providers in the country about 10 years ago. And so I was doing Myobrace a long time ago. The Myobrace can do a great job at helping to level the arches. It's going to bring those central incisors down.
Yeah.
But it can help bring the lower jaw forward a little bit.
Yeah.
But the upper jaw is already too far down.
Too far down?
Yes. Do you measure her indicator line?
The indicator line. Normally I do, yes. She's new. I didn't do this here. Indicator line. So indicator line is important for you.
So the indicator line is going to show the vertical growth compared to the horizontal or the forward growth.
Yeah. Okay.
So to my eye, I see a gummy. She's very gummy on the sides, like her centrals are above the lip line, but all of her canines and primary molars and 6-year molars, I see a lot of gum. The maxilla looks too low, and all of her upper teeth are kind of angling inward.
Yeah.
And I think it would be good to get her up and forward more and help the lower jaw develop forward 10 millimeters.
Uh-huh.
With the Myobrace, you can level things out, help the lower jaw come forward maybe, 2 or 3 or 4 millimeters. But there is a component that's going to help, that's going to keep the downward growth going a little bit. The Myobrace does not really get forward development of the maxilla.
Yeah.
And the Myobrace does not get upward development of the maxilla.
Uh-huh.
Yesterday, I had a patient who was not this bad, but her jaw growth was bad and she couldn't close her lips. And this looks like a mouth breather.
Yeah.
But I had an adult lady that she couldn't close her lips. And so they took out 4 premolars on her and made her mouth smaller, and she was still a mouth breather. So then they surgically moved her maxilla up, and her lower jaw surgically moved it back behind the smaller maxilla to help her close.
Terrible.
What we want to do is get her maxilla up and forward to help the lower jaw develop forward with that.
This is an orthotropic appliance you would need here, would do here.
Are you familiar with orthotropics?
Not only a little bit. Barry showed me a little bit orthotropics. It's a very special, this orthotropic thing.
Dr. John Mew, who started orthotropics in the
Yes.
1950s in England. Most people today who do orthotropics, I know a lot of dentists trained on traditional orthotropics, and they do 1, 2, 3 cases and they never do it again. It's extremely difficult. It's extremely uncomfortable. And it's like if you're going to travel from Europe to United States on a sailboat, it's exciting. It's adventurous. Some people may want to do that one time. Okay. But to do it once a month, consistently, frequently, no way. We're going to take the airplane.
Of course. So
Right.
so orthotropics, I do not need to learn.
That's right. You do not need to learn orthotropics. So orthotropics is a phenomenal way of doing things, but the appliance I developed is like the airplane of orthotropics.
Okay.
So it's simple.
So it's your special appliance.
Yes.
Okay, good.
So the Crozats were in the early 1900s, and these are soldered, and these wires are bent to widen and develop the arches. You're probably familiar.
Yes.
Have you used them?
No.
Okay.
No.
But they help you bend these loops, and they help to give more width.
Yes.
You can have wires in the anterior to help tip or develop the teeth. You can bend these loops to help open up the anterior. There's a lot of different loops here that can open. And then in the 1980s, they took the Crozats and made a light wire. So the ALF, are you familiar with the ALF?
I heard it from Barry Raphael.
So it's advanced light wire. So the Crozats are like a 1 millimeter wire. The ALF is like 0.7 of a millimeter.
Uh-huh.
So it's going to be softer. It's less force. It's going to be slower movement, but it's all about the cranial bones. So it's to correct distortions of the skull, the maxilla, improve the bite. It's much slower, but the cranial bones will flex, and there's fluid in our fascia system and things, and the ALF allows for natural flexion of the maxilla because there's 2 parts, the left and the right, and it's a gentler approach.
Yeah.
So here's the ALF, and there's the loops, and you can bend them and create tooth movements. This is all primary dentition. So this is a case with the ALF. You know, they widened this out. You can see the space. They widened this.
Yeah.
And they widened the upper, and that helped to bring the upper down. And the Myobrace can do something like this also. What this did not do, this did not get the up and forward. So here's some different cases. These are with the ALF. It'll get these front teeth in front of the lower here. It'll get this crossbite corrected. It can widen out. Here's another crossbite. It can widen out. And there's different ways you can do lateral expansion. The Myobrace can help correct some of these. So here's the Myobrace, and how many years have you been doing Myobrace?
3-4 years.
Okay, so it can help do some of these things with good compliance. The Healthy Start is similar to the Myobrace.
Yeah.
Then there's the DNA Appliance, which was somewhere about 2000 or 2010 up until 2017. Vivos took them over. Have you heard of this one?
Yes, I heard this one from Barry also.
Okay, so this is something that's going to give lateral expansion up in the palate. It's going to increase the width.
That's what we often do with these plates, the Schwartz plates in the middle.
Yes, with the Schwartz plates, that's the same. Sometimes there can be some springs in the anterior. So this will have springs in the front to help push this forward. So as this widens, it'll help to bring the front teeth forward a little bit. This takes up a lot of tongue space. A lot of people are uncomfortable because the tongue is crowded.
Yes.
Here's orthotropics in the 1950s. So this appliance widens and it helps to bring everything forward. So this is an orthotropics appliance right here. So it's going to give the width here.
Yeah.
And this spring can bring all the front teeth forward a lot.
Yeah.
As the front teeth come forward, they get flared out.
Yeah.
Front facing.
Yeah, I saw this.
Okay. So you saw that. So, and it does not bring the bone with it. It flares the teeth out. The bone is still mostly back. The lower jaw is still back.
Yeah.
After this appliance, there's the second appliance, which is this.
Yeah.
So the front teeth are flared out. This goes over. This wire that comes down locks behind the lower jaw. So the lower jaw normally, after the orthotropics, the lower jaw is back here like this.
Yeah.
With this appliance in, now the lower jaw, instead of, it can't close here. So it's got to come forward and close here.
Yeah. We have a similar appliance this in Germany.
Okay. That forces it forward.
Forces forward, yeah. I'm using children from 10 to 13 or 14. In this area, I'm using this to bring the lower jaw forward.
Yeah. Okay. The nice thing about this is that it's not really pulling the upper jaw down and back too much. The child has to use their own muscles to hold their lower jaw in the proper place.
Yeah.
And the wires are a guidance.
Yeah.
But it's uncomfortable, and a lot of kids don't like to use it, and there may be an issue with compliance. You tell me, is this easy for a lot of the kids, or is this uncomfortable and hard for the kids?
You know, there are always some kids where compliance is not good, but of course it's not very they don't like it so much.
Right. And so that's the thing with orthotropics. This is a good thing. You're trying to really, really help them, but it's difficult because they don't always like doing it.
Yeah.
So I want to show you my system and what's different about it, and how there's some advantages that can make compliance easier, make it more comfortable, and working with physiology instead of forcing physiology so much. So You understand a lot of this, Joseph, so I'm going to kind of
Yes.
go fast.
Yes, you can go fast.
You tell me if you want me to slow down or speed up.
Yes, you can go fast, and
Okay.
I will tell you.
So this maxilla is too far down
Yes,
and it's retroclined. There's a lot of crowding here, lack of space for the permanent teeth. This is down too much.
a little bit similar to the case we saw, this one.
Yep, this is similar. The lower jaw is back, crowding here. Not too much of a gummy smile, but it's underdeveloped. A lot of crowding there. This is down too much, underdeveloped jaws. So we take her here from needing being an extraction case to developing her here, more than enough room for the teeth to come in. This girl, happy smile, but you can see she has vertical or downward growth. Gummy smile, this is down too much. Her lower, the incisors are coming in behind the primaries.
Yes.
So this is a sign the jaws are underdeveloped. We want to get the face forward. We want to develop this with everything coming forward at or ahead of the bridge of the nose as much as we can. This is someone who did not do treatment. Her face was looking okay here, but by her indicator line measurement from the nose to the teeth, her development was down too much. So a couple years later, without treatment, you can see the upper jaw continue to grow down and the lower jaw continue to rotate down and back. This is what my appliance does. My appliance gets the maxilla up and forward and helps to develop the lower jaw forward without one of the appliances that has the bars coming down on the lower.
That looks good, yeah.
So this is bringing her 10 millimeters forward. So right here, we're not bringing the lower jaw forward a little bit to match the upper. We're bringing the upper up and forward 10 millimeters and bring the lower forward 10 millimeters. Does this seem like a good thing for the patients?
Yeah, that's excellent. 10 millimeters.
So looking at the nose lip angle here, this is higher than 90 degrees.
Yeah.
And now with the nose lip angle here, it's 90 degrees or maybe slightly less. And we see this coming at age 2. So right now, age 2, the maxilla is down too much. Do you agree?
Yeah.
Vertical growth pattern, mandible, lower jaw trapped back, restricting the forward growth. Do you agree?
Yes, I agree.
So she's waking up crying twice a night. And today in the United States, most people think, oh, that's normal. She's 2 years old. They wake up a lot during the night. But we make her an appliance to grow her jaws properly and unrestrict the lower jaw and get the upper jaw growing up and forward. And within a week, she's sleeping through the night.
Within a week.
That's right. But this girl, so at age 2, if we try to do something with this, how likely is she to still have crowded teeth?
Yeah.
Because all of these cases back here in the primary dentition, they had no crowding, inadequate space in the primary dentition.
Yeah.
So we see this at 2 years old, she's going to have crowding.
Yeah.
Her face looks okay here, but this upper jaw is down too much. The deep bite, the lower jaw is trapped back. This is high risk for sleep apnea later in life, TMJ, migraines, right? So we see the gummy smile, the maxilla down too much. Here's another one, the maxilla down too much. And we get this maxilla up and forward, not let it continue growing down. So this at age 2, we don't know what's going to happen, but we do know this is going down too much.
Yeah.
So this is with our appliances. We get the maxilla growing up, getting it back upward and forward with the bone, not just flaring the teeth out. We did not do anything to the lower, but the lower jaw helps to develop all by itself.
Yeah.
So the lower jaw is unrestricted and it can grow all by itself now. So the bite goes from this to this, getting the maxilla upward and forward, and the lower jaw comes forward with it.
Well, that looks excellent.
So this is only forward development. The overjet is about the same. Here's another case, 3 years old. The maxilla is coming down. It's restricted. This is all leaning in. But we developed this up, forward, out, creating a lot more space here. He starts to get, so he's starting to get his permanent teeth, but what do you think here, Joseph?
Excellent upper jaw development.
And this is forward, so this is six millimeters forward here, and the lower jaw developing forward with it and making space for the permanent teeth. And you've been doing Myobrace. Have you seen something like this with Myobrace?
No, never.
So this is not going to happen with Myobrace.
No.
About what other systems? Now you can create space with lateral development going sideways, but you want to get the anterior. You want to get the forward.
Yeah.
So
I have no appliance which can do this.
And that's what we want to do. We want to spread this across the world and make this the standard of care, because we want to get the mid face developed forward.
Yeah.
So here he is, 3 years, 9 months here, and then 5 years, 6 months, getting everything forward, the bite improved. And I think here he could go back and close all the way down. But you know, with kids, they want to breathe and they're more comfortable closing here unless they have to chew, then they close back.
Yeah.
He was just kind of posturing forward. We couldn't get him to go back for the picture. But here he is here with the lower jaw rolling backward, and we help get this lower jaw coming forward much more.
Looks great.
So here's his smile. You see this rolling back, and we get this up and coming forward. So there's the nose lip angle here. That is one thing. The nose lip angle here, flat lip here, nose lip angle higher than 90 degrees. Lower jaw way back behind the bridge of the nose. Here's the bridge of the nose. If you draw the line, the lower jaw is way back behind that. Here, the nose lip angle is about 90 degrees. And the bridge of the nose, the lower jaw is much closer here.
Yeah.
Here, we're looking at the nose lip angle and you think, oh, it's close to 90 degrees. It's not too far more, right?
Yeah.
But look at the bone. If we go to the bone and take this nose lip angle to the bone, it's going to be much higher.
Yeah.
And if we go to the bone here, it's going to be a lot better.
Mm-hmm.
And so sometimes the lip only can be deceiving. But the bone underneath it is what supports the tissue. As we get older, the tissue starts to get relaxed and loosen and sag down more. And where the bone is really want to see. The more the bone is developed, the better the lower jaw can develop in a better position.
Mm-hmm.
Here's a class 3 case. This upper jaw is very back.
Yeah.
And the Myobrace can help with some class 3 cases, but when it's really significant, the Myobrace, it'll almost bring the lower jaw back and maybe meet in the middle. We don't want to do anything to bring the lower jaw back. We only want the upper jaw to come forward, right?
Yes.
So the Myobrace I3, it's going to bring the upper jaw forward a little, but it's going to bring the lower jaw back. So this is just bringing the upper jaw forward. Here's age 5. Head tilt, chin lift. This is an airway posture. Later in life, he's going to have neck pain and back pain. So you see the chin up.
Yeah.
The nose lip angle is about 90 degrees. It looks okay, but that's because he's young and healthy. If we measure the indicator line from the tip of the nose to the edge of the teeth, the indicator line is going to be high. The maxilla is growing down too much. The lower jaw is trapped back, wetting the bed twice a night.
Oh.
He's going to have crowded teeth. This is all primary dentition. We develop him out. He has room. All of his permanent teeth come in perfectly straight, no crowding. We get the lower jaw developing forward, no more bedwetting, sleeping through the night, and a much better development pattern.
It looks great.
So here he is at age 5, lower jaw trapped back, upper jaw coming down too much. We see the overbite, and this is what you were showing me, right?
Yes.
Except we let this go a little bit older, and it's going to be similar to a lot of kids. So we get him here. This forward, the permanent teeth have room to come in. Much better jaw, much better bite. One of the questions with this is, are these primary molars going to be distalized and move backward and stop or impact the 6-year molars? This shows the 6-year molars kind of behind these primary molars, and they may distalize a little bit. It may delay the eruption a little bit, but they always find their way up and they come in just fine. So the lower ones came in nicely. The upper ones were a little slow. We took the x-rays to check them, but here's the 6-year molars, you know, coming in up here just fine.
Yeah.
So here's his appliance. So we want to get more forward development. So we've done a lot for him, but this is still going in too much. We want to get this up and forward more. So he's got his appliance in. The lower jaw is looking very nice, but we want to keep things going forward. Notice this has occlusal coverage.
Yeah.
And this is flat on the occlusal.
This is your appliance.
This is my appliance. So this is flat on the occlusal.
Yeah.
Neurologically, we need to breathe.
Yeah, of course.
People are going to posture to breathe. We're going to do the forward head posture or the chin up. We're going to open the airway so we can breathe.
Yeah.
We're going to open our mouth so we can breathe, right?
Yeah.
Neurologically, our teeth have to chew.
Yeah.
We have to eat.
Yeah.
So we have to have a bite.
Yeah.
And the teeth need to puzzle piece together. When we start to develop the upper jaw with my appliance, when we start to develop the upper jaw, if we don't have the occlusal coverage, if they're in the normal bite, the lower jaw stays where it is because they have to keep the bite. They have to chew.
Yeah.
When we put the smooth surface over the bite, the lower teeth do not lock in.
Yeah.
They do not puzzle piece together. There's no bite. The lower jaw is on ice skates.
Yeah.
And so the front teeth want to feel where each other are. The lower teeth look for the top front teeth. And if they have good oral posture, if they start closing their lips and breathing through their nose, the lower jaw develops naturally forward with the upper jaw. And so that's how we can bring the upper jaw forward and upward 10 millimeters and guide the lower jaw to develop forward with it. Now, there may be case by case, there may be a few cases or some cases that you may still need some of your other appliances. But most cases, if the kids have good compliance with this, this is all they need.
This is all they need.
That's right. Now, now they wear this. We do this with kids and adults.
Adults also.
Adults also. The kids from age 2 to 10, they wear this full-time 24 hours a day. They take it out to brush their teeth. They eat with it in because we're guiding the lower jaw forward with it.
Yeah.
If they take it out and eat, then the lower jaw is going to be more likely to stay back where it was. So with the adults we have them take it out to eat, and it needs to be out at least 2 hours a day with the adults because we don't want to get TMJ changes. So there's a little different protocol with the adults, but with the kids from age 2 to age 9 or 10, they eat with it in. Once they start to get 11, 12 years old or teenagers, they eat with it out. But sometimes we do some bonding or some different things. But generally having this smooth plane here helps to guide and achieve the forward development of the lower jaw at the same time with the upper jaw coming forward. The appliance that you have the Schwartz, you're getting the sideways or the lateral growth, and we're getting the lower jaw forward up to where the upper jaw is.
Yeah.
But what I'm doing is I'm developing this upper jaw another 5 or 10 millimeters farther forward and bringing the lower jaw forward with it that much more.
That's great.
Do you feel like that's a good thing?
It's unbelievable that you can do this.
So are you interested in learning the next thing?
Of course.
So these are Myobrace examples. There's no room for the canines. So this is the Myobrace BWS. You're familiar?
Yes.
And sometimes because of the force on the crowns of the teeth, it can create root resorption. Sometimes there's pressure up on the crown, and too much pressure can create root resorption. This is all on the teeth. We're not developing the bone here. This is all on the teeth.
Yeah.
We use our removable appliance to develop this out, make plenty of room here, and then put her in braces. So this case right here is only Myobrace. So we went right here only with the Myobrace.
Mm-hmm.
The bite's gonna come together. He has a pretty good bite, very straight teeth, nice smile. The parents were very happy. This is no braces.
No braces.
No braces, only Myobrace. But then I look and the nose lip angle is higher than 90 degrees.
Yes.
His indicator line measurement is way too high.
Yeah.
So yes, we got the teeth straight without braces, but I realized this is not maximizing the airway. We didn't get the upper jaw forward as much as ideal. We didn't get the lower jaw forward as much as ideal. Here's another one just with Myobrace. So we had her something like here with Myobrace, and this is pretty good. But her parents, once I started doing my appliance, we finished like this with Myobrace, but then her parents wanted to do my appliance, and we developed this much more space behind the canines, and the lower jaw came forward with it.
That's great.
So another 4 or 5 millimeters forward of space, the lower jaw, 5 millimeters forward, without the appliance that comes down, right? This
Yeah.
is just with my appliance with that flat plane, the lower comes forward with this. Is this good to get kids another 5 millimeters forward if they want to?
Yeah.
And in the young children, her premolars and molars would really kind of migrate forward on their own. Or if we want it to happen faster, we can use braces to bring the premolars forward and then bring the molars forward, keeping everything forward.
Yeah.
Right. So this is another Myobrace example here. So this is only Myobrace, straight teeth, nice bite. He's doing really well here. Nose lip angle is okay. The bridge of the nose, the lower jaw's back a little bit more than I would like.
Yeah.
Looking at the smile, when he smiles at this profile, if I go to the bone here, this is going to be higher than 90 degrees.
Yeah.
Yes, Myobrace was good. This is better than retractive orthodontics. But I realize now with my appliance, I could have done more to get this lower jaw forward. So this is with my appliance, our Airway, Tanner Airway Appliance. So this is similar to the case you were showing me here.
Yeah.
Upper jaw down too much. We see the restricted growth of the maxilla. And we could use an ALF or a Crozat to widen this. We could use a Schwartz to widen this.
Yeah.
But my appliance is going to help get this up and forward, reverse this gummy smile here, and get this lower jaw forward more than anything else. So this comes in quite a bit, her lower jaw rolling back. So this is bringing her forward. So we develop this lower, the upper, we get this up and forward. So as the anterior teeth come upward and forward, the sixth-year molar goes up and back. So it kind of hinges a little bit. And then what I do, the bite is down here. Can you see how these primary molars, the E's, they're flat?
Yeah.
I grind them down. So I drill them and I grind them down almost to the gum line. You can see we're almost showing gum tissue here. As the roots start to resorb, I want to bring the bite together. If I left that molar, you can see how flat that is, Joseph?
Yeah.
If I left a full tooth, she would be closing down. So if I left this full tooth, she would be closing down a lot sooner, and this would be open in the front. But as this upper comes up and forward, the lower, I grind down these baby molars so that the lower jaw can rotate forward. Does that make sense?
Yeah, makes sense.
This is my lower jaw.
Yeah.
Upper jaw grows down. This is the TMJ.
Yeah.
This is the mandible and the front teeth.
Yeah.
This is going to open and close on an arc in a circular motion.
Yeah.
As the upper jaw grows down too much, the lower jaw is now going to close here.
Yeah.
If we get the upper jaw back up, the lower jaw can close higher up.
Yeah.
Because it's on an arc, when it's lower down, it's farther back.
Yeah.
When it's higher up, it's farther forward, right?
Yeah.
And so anything like headgear or the class 2 elastics in Germany, do they do the rubber bands between the top and bottom?
You do class 2 elastics, yeah?
So those are going to pull the maxilla down a little bit.
Yeah.
And they're going to try to get the mandible to come forward, but it's going to meet in the middle. This is going to come down a little bit. The lower jaw is going to come down and trap back.
Yeah.
And I just had a patient yesterday that had this done, and he has TMJ problems, and I can show you his case and what happened with his TMJ. But when we restrict that lower jaw, it's coming down, and on a rotational path, down is also back. When I take these upper and grind this down and make these flat, it's helping the lower jaw to close higher. Does that make sense?
Yeah, makes sense.
So this was, she's biting. We have these bite pads here. She's biting here. We close this down. I'm going to flatten the lower arch. That's easy to put the braces and flatten this out. But right now we're developing the bone. and we can straighten up the top, but we're developing the bone and opening the airway as much as we can. So this is down and back quite a bit, and we get this up and forward much more here. So this is rolling back a lot more, but especially here, you can see the spacing issues here from the lateral to the primary molar. This is maybe 6 or 7 millimeters here. From the lateral to this premolar this is now we've got like 12 millimeters. You know, we have a lot of extra space, but she's here. So downward vertical growth here, upper jaw down too much, and we're able to get this up. You see the gums back here?
Yeah.
And now we see the teeth. There's less gum tissue there.
Excellent.
Do you like this?
Oh, very much.
Okay, do you think this is a good treatment option for your patients?
Nate, I've never seen this before.
Okay, no, that's great. That's great. So tell me your feedback. What do you like about this? Do you think this is a valuable approach?
This is what we want. This is all what we learn in airway. All what we want in airway, you know, bring the upper come forward, up, and the lower comes with it. But the only thing what I learned in airway collaborative, this was only possible with this orthotropic thing till now.
That's
and
right.
I never liked it when I saw these teeth coming flared out, and so it looked so terrible. I couldn't do this.
Right, right.
I cannot do this in Germany.
You'll lose patience.
Yes, and you know, it looks too strange.
Right, that's right. Well, and it's very difficult and emotionally challenging for the kids.
Yeah.
Have you ever seen a way to do it without my appliance?
No, I've never seen this before. We don't do this. We at the end they are all have all airway problems. Nobody can do this. Bring it forward, and I've never seen this.
And this is bringing the bone forward with it.
Yeah.
Now, one thing I'm starting to do is sometimes I'll do the braces and straighten up the front teeth in the beginning so it looks nicer in the beginning.
Okay.
You can do braces in the beginning or at the end. You can do braces just on the front 6 at the same time as my appliance. And the parents like that.
Yeah, of course.
And we can set the angles on those screws if we want more upward, if we want more width, if we want straight forward. You know, we can customize this for what's best for the patient. But this is nice because it's going to give width. Like on my case right here, like right here, this is good. She ended up with very nice width here, right?
She's excellent. Excellent.
This is no paddle expansion.
No palatal expansion.
Only my appliance.
And the teeth are not flaring out like this.
No, because we're working with physiology. So this appliance stimulates normal physiological bone growth and development.
And is it difficult to learn your appliance?
No, it's not.
How much time would it need?
Well, you need, we could send you some appliances to kind of use and practice with a little bit.
Yeah.
But it's a little bit of wire bending with the clasps and then the acrylic, working with the acrylic. So when they come in, if they're eating with this in, they're going to start to wear little bite marks in this.
Yeah.
So when they come in, we smooth it off. We just take an acrylic burr and we smooth it off to keep it flat. Sometimes, depending on the growth, we're changing the direction of growth.
Yeah.
So sometimes we do an acrylic reline in here.
Yeah.
As the direction of growth changes on the maxilla,
yeah,
the fit of the appliance changes, And so sometimes we do an acrylic reline. Have you ever done acrylic reline on a denture or appliance?
Yes, you know, grinding down the teeth, it's always a little bit, yeah, you don't want this with children to grind down but I think it's necessary. It's necessary to bring the upper jaw forward, and I see the necessity, right?
Mm-hmm.
I see this, but yeah.
Yeah.
First, you don't like this to grind down teeth, right?
That's right. That's right.
That's right. We don't like this, but it's for a good purpose.
Right. And I don't do that on all cases. It just depends.
Okay.
You know, you don't have to do that.
Yeah.
But some cases, there's a benefit.
Benefit.
Yeah.
Just the gummy ones. The gummy ones. You showed
Right.
me.
That's right. That's right.
The extreme gummy.
That's right. And there's no numbing. There's no numbing. The root, I do it when the roots are already resorbing. I don't numb. I just drill them down. They don't feel anything.
You do it in the age 10 and older, 10, 11, 12, when the teeth come in, or which age?
Right. Yeah. Somewhere in there. I mean, maybe age 9 or 10, I can take off the cusp tips a little bit.
Cusp tip, 9, 10, yeah.
And then just add, something, but.
After 10, they are erupting then. After 10, most times in this time range, the 10, 11, they are erupting then.
Yeah. I mean, I have seen an 8-year-old with all permanent dentition.
Yeah, so it's a rare, but yeah, okay.
So it just depends. Yeah.
Variability.
Mm-hmm.
Okay, thank you so much. Great, Nate. That was a great hour with you, or 1.5 hours. It was great. Your cases are phenomenal. I've never seen these cases before. Never before. Upper jaw is not going forward, and lower jaw we can a little bit bring forward, but it's mainly the upper jaw. And then we take this delay mask, we can pull the upper jaw forward till 10. And it's done.
Right.
Then we only can go transverse.
Right.
That's the only thing we do.
Right. And so you see the benefits of this then?
Yes, this is what we want. We want to your cases look like John Muse cases. They go forward. John Muse. It's like orthotropic.
Right.
You have a lot from orthotropic, but in a better way.
That's right. So orthotropic means straight or correct growth and development.
Yeah.
And this is orthotropics because we're getting optimal growth and development.
Yeah.
But it's not flaring the teeth. It's not like the normal orthotropics. Yeah.
Okay, Nate, thank you so much for your time.
You're welcome. Thank you, Joseph.
I will come back.
Okay.
Thank you. Have a great time.
Okay.
Yeah. Bye-bye.